study, and that is Triton, the first United States-based large-scale pivotal randomized trial. This was a prospective study of a dedicated side branch stent versus provisional side branch strategy in true coronary bifurcation lesions, and this trial will be presented by Martin Leon.
Greg, thank you very much. It's truly a pleasure on behalf of the Triton bifurcation trial investigators. This was truly an international study to present the Triton bifurcation trial. I have no personal conflicts associated with this study, although we do receive some research support from other strategic interventional companies. The purpose of this trial was to compare the clinical outcomes and angiographic results of the accepted provisional one-stent strategy versus the Triton dedicated bifurcation stent two-stent approach in a randomized controlled trial of true coronary bifurcation lesions. For those not familiar with the Triton side branch stent, it is a three-component device with a side branch component that looks like a typical stent, 6.5 millimeters in length, that supports the side branch zone. There is a transition zone of 4.5 millimeters, which supports and extends over the ostium of the side branch, and then a low metal content, 8 millimeter long main branch zone, which supports and integrates with main branch stents. It is intended to be used in a two-stent strategy. It is a cobalt alloy bare metal stent. There are many different sizes available with a stepped balloon that allows for the difference in size of the side branch versus the main vessel. The size matrix is shown here. The deployment sequence consists of first implantation of the Triton stent after wires are placed both in the main and side branches and pre-dilatation is performed. After deployment and rewiring the main vessel, then an approved drug-eluting stent is placed through the main vessel portion of the Triton stent. And after deployment of the main vessel stent and rewiring of the side branch, kissing balloon dilatation is performed. Once eligibility criteria have been established, we randomize 704 patients to either strategy, which is the control provisional side branch strategy with a DES in the main vessel versus Triton first and then a drug-eluting stent in the main vessel, two-stent strategy. Primary endpoint was a clinical endpoint of target vessel failure at 9 months. There is a robust angiographic substudy with a secondary powered angiographic endpoint in 374 patients. Additional substudies in an IVUS cohort and 3D angio cohort will not be reported during this presentation. The inclusion criteria were single de novo true bifurcation lesions as established by site investigator interpretation using Medina classification. Patients had to have symptoms or objective evidence of ischemia. Importantly, the vessel diameter for the main was 2.5 to 4 millimeters. For the side branch, it was intended that these be large side branches, 2.5 to 3.5 millimeters in size, with a lesion length of less than 28 millimeters in the main and less than 5 millimeters in the side branch. There was limited treatment of multivessel disease and staging per protocol. There were several key exclusion criteria, which were clinical, including STEMI, hemodynamic instability, renal insufficiency, and low ejection fraction, and several anatomic exclusions, including left main disease, either protected or unprotected, trifurcation lesions, extreme complexity in morphology, including thrombus or severe calcification. This was an intent to treat study design as the primary analysis cohort with a 1-to-1 randomization. The primary clinical endpoint of target vessel failure at 9 months was defined as cardiac death, target vessel MI, where the criteria for target vessel MI included a peri-procedural 3 times normal CKMB elevation, which was at the time the ARC definition that was appropriate, and target vessel revascularization that was ischemia-driven in either the main or side branch. This was a non-inferiority comparison. The secondary powered endpoint was percent diameter stenosis in segment of the side branch at 9 months in the angiographic cohort only, and this was a superiority intent. There were specific operator technique recommendations for the Triton pre-dilatation of both arms to achieve optimal lesion preparation, Triton placement followed by additional dilatation at the ostium to optimize the ostial inlet, and then drug-eluting stent placement followed by final kissing balloons with non-compliant balloons. In the provisional arm, standard operator technique for pre-dilatation and DES placement. Side branch intervention was allowed, either balloons or stents or pharmacotherapy only if the TIMI flow is less than 3. There were type B or greater dissections, or there was a very obvious angiographic stenosis of 80% or more, and it was strongly recommended that final kissing balloons with non-compliant balloons be performed also in the provisional arm. The trial was administered very aggressively with the help of Patrick Sarais as the study chairman, a very involved executive committee, and the other components are listed on this slide. This is a difficult study to enroll. It took 23 months to complete enrollment of 704 patients, including a total of 58 sites, 28 in the US and 30 outside the US. The US enrolled 32% of the patients, outside US 68% of the patients. I'd like to congratulate many of the high enrolling sites, including Dr. Kamsars, who is the highest enrolling investigator from Latvia, and the Mount Sinai group, the highest enrolling site in the United States, and these are sites that enrolled 10 or more patients. Of the 704 randomized patients at 9-month follow-up, 97% had fully complied with all the clinical follow-up criteria. And of the angiographic cohort, we had angiograms to examine in 326 patients with an angiographic follow-up rate of 87%. These are some of the patient demographics, typical age of 65 years. Overall diabetics were about 25%. All other features were balanced in both groups. This was, for the most part, a study of patients with stable angina, 3/4 of the patients, and relatively mild symptoms, as you can see here, with 2/3 of the patients receiving a functional test indicating ischemia and generally preserved ejection fraction. The vessel location was LAD in 3/4 of the patients, just under 20% in the circumflex, and about 6% in the distal right. For the main vessel, it was mainly proximal and mid-location, and by QCA, the reference vessel diameter in the main vessel was 2.9, and the lesion length was about 16.5. In the side branch, now the lesion location was more than 97% of the time at the ostial location, as anticipated. The measured reference vessel diameter for the side branch was 2.21 and 2.25 millimeters respectively, and the average lesion length was about 4.5 millimeters. This is the site-reported Medina classification, true bifurcation listed in the 3 categories on top. For both groups, more than 99% of these lesions were interpreted as being true bifurcations by the site. However, when subjected to rigorous core lab assessment with a diameter stenosis cutoff of 50% for all lesions and all locations, that number of true bifurcations drops to approximately 88%, which is not unexpected. There are some interesting procedural details. Non-target lesions were treated, as was permitted by staging, in about 15% of cases. The Triton was successfully implanted in the Triton arm in 96.1% of cases. In the provisional arm, pre-dilatation was performed in 61% of cases, and final kissing balloon dilation in 86%. In the Triton arm, 96% had pre-dilatation, and 85% had final kissing balloon dilation. When we look at crossover for additional stents in the provisional arm, there were 28 of 349 cases, or 8%, using the strict criteria that were just outlined. There were a few crossovers in the Triton arm with additional stents as well. These are the main study results. The primary endpoint, the composite target vessel failure endpoint, was 12.8% in the provisional arm and 17.4% in the Triton arm. If we look at this slightly differently, the difference was 4.6%. The 95% upper one-sided confidence interval was 10.3%, with a zone of non-inferiority that was pre-specified at 5.5%. This study did not meet its primary non-inferiority endpoint. What were the components of the composite endpoint? There were no cardiac deaths in this study. The primary endpoint was driven by target vessel myocardial infarction, and more than 90% of the target vessel myocardial infarctions were periprocedural. Clinically driven TLR was low in both groups, 3.6% in the provisional arm and 4.7% in the Triton arm. Stent thrombosis was rare. Overall, 0.4%, 2 cases in Triton, 1 in provisional, very low in both groups. Angiographic follow-up indicated excellent results in the main vessel for both arms. There were some differences in the side branch. So in segment, MLD was greater by 0.2 millimeters with Triton versus provisional, which was highly significant. And the powered secondary endpoint in segment percent diameter stenosis, as you see here, was also significantly different. And shown here was 38.6% in the provisional arm, reduced to 31.6% in the Triton arm, so the secondary superiority angiographic endpoint was met. If we look at the cumulative frequency distribution curves just at the side branch of percent diameter stenosis, you see at baseline slight differences, a large separation associated with better acute results with the Triton in the side branch. And then these curves come together somewhat, and if you look at the cutoff of 50% diameter stenosis, you can see that they're in fact very close. And this translates into no statistically significant difference in binary angiographic restenosis in the side branch, which was 27% in the provisional arm and 23% in the Triton arm. The location of restenosis, as expected, was at the osteal site in both provisional and Triton arms, 75% of the time in the provisional arm and 62% of the time in the Triton arm. We did several important post-hoc subset analyses. First, the sensitivity analysis looking at the impact of changing CKMB rises on target vessel MI. You can see that as we move to more clinically relevant definitions of periprocedural MI, that the numbers scale very dramatically, with a very low number if you use the more recently publicized, clinically relevant 10 times normal CKMB rise. We identified what we call the oculostenotic paradox, which is this dramatic difference between what was angiographic restenosis versus clinical TLR. And in an important analysis, looking at the side branch group that was by QCA greater than 2.25 millimeters, which visually translates to about a 2.5 millimeter side branch, the intent of the study, in 282 patients, which is 41% of the study, we saw completely different results. We saw in this case, Triton was somewhat better than provisional, 15.6 versus 11.3 in target vessel failure, with lower periprocedural MIs and slightly lower clinically driven TVR. In fact, if you use the same statistical modeling, this would have achieved the non-inferiority boundaries just within that subgroup, and a similar amplified improvement in the angiographic analysis in these larger side branches with less restenosis and with an improvement in in-segment percent diameter stenosis. So to conclude, the Triton two-stent strategy in true bifurcations, 88% confirmed by QCA, compared with the provisional strategy with an 8% additional side branch stent rate, did not meet the non-inferiority clinical endpoint of TVF due to a relatively higher frequency of small periprocedural CKMB elevations. However, both strategies were safe. There were rare clinically significant MIs and stent thrombosis, and both had low 9-month clinically driven TVR. DES in the main vessel performed well in both arms. Triton did improve side branch percent diameter stenosis at follow-up. And in post-hoc subset analyses, there was a striking disparity between binary restenosis and clinically driven TVR for both arms, indicating that side branch angiographic restenosis is uncommonly expressed clinically. Improved clinical and angiographic outcomes with a Triton in larger side branches certainly was an interesting observation in this study. And finally, what are the clinical implications? It's difficult to enroll complex high-risk bifurcation lesions in clinical trials. Even though we tried, only 41% of the patients truly had large enough side branches to have conformed to the intended enrolled population. Small periprocedural CKMB elevations do occur more frequently with a two-stent strategy, and that tends to dominate the clinical endpoint. Moderate stenoses and smaller side branches are not clinically active, this so-called oculostenotic paradox. And in large side branches, larger, 2¼ or more by QCA, a Triton two-stent strategy appeared, this is hypothesis generating, appeared to improve side branch angiographic results and clinical outcomes. Thank you.